It is my pleasure to introduce the next speaker, Mr. Dr. Hassan Albalas. He is Associated Professor and Chairman of Radiology Department in University of Erbil, Jordan. Hello.
Thank you very much for the introduction and the opportunity to present this. Hopefully, was less controversial subject, but unfortunately, we're going back to controversy. As you know, the narrowing of the renal artery can result from different pathology. Each of them has different pathophysiology and clinical features, but most of them are related either to atherosclerotic renal artery disease or fibromuscular dysplasia. There are other rare entities that can result in renal artery stenosis. Almost 90% of all cases of renal artery stenosis are caused by atherosclerosis, atherosclerotic renal artery stenosis. In a study on general population who are 65 years old and older, and using Doppler ultrasound, defining renal artery stenosis by 60%, the incidence was almost 7%. So it's a very common disease, especially in elderly people. If we took the people who have coronary artery disease or hypertension or renal impairment, the incidence can go up to 50%. Renal artery stenosis secondary to atherosclerotic disease usually involve the aorta and extend into the ostium, so usually involve the proximal part of the renal artery. Fibromuscular dysplasia is also a heterogeneous group of disorders that can involve any of the layers of the renal artery. The most common is medial fibroplasia, which accounts for 80% of the cases, usually affect young ladies less than 30 years of age. Hypertension is common, but renal impairment is rare and usually involve the distal segment of the renal artery. What are the clinical manifestations of renal artery stenosis? It can be divided in two categories, either cardiovascular or renal manifestations. Cardiovascular hypertension is probably the most common. What's called recurrent flash pulmonary edema without underlying cardiac pathology, or acute coronary syndrome like unstable angina in a normal coronary anatomy. Renal manifestations can result in acute or gradual onset of renal impairment. Acute usually can result from starting angiotensin-converting enzyme treatment, and usually is bilateral. Now, the big question is the relationship between renal artery stenosis and hypertension, what's called renovascular hypertension. I wish I have a very easy definition, but simple, is renovascular hypertension is hypertension resulting from significant stenosis of the renal artery. The only way to prove it is to correct the renal artery stenosis and cure hypertension, and it's not that easy. Almost up to 4% of all patients with hypertension may be related to renovascular hypertension, and most of our understanding for the association between hypertension and renal artery stenosis came from Goldblatt's work on dogs, where he ligated the renal arteries and he studied the changes in the blood pressure. This is the simplest way to understand renovascular hypertension. Stenosis result in renal ischemia, increased renal excretion, activation of the renal angiotensin system, result in sodium retention, as well as systemic vasoconstriction resulting in hypertension. But unfortunately, if you look at chronic phase of renovascular hypertension, the renal angiotensin system is not chronically activated. Actually, it goes back to normal. For renal impairment, what's called ischemic nephropathy, which is the second important manifestation of renal artery stenosis, is loss of renal function with time secondary to stenosis. Now it's believed is the third most common cause of end-stage renal disease in the United States. The process starts with renal ischemia, then there is fibrosis, resulting in shrinking of the kidney with different agents and become irreversible. Revascularization technique started with surgical revascularization in 1962. Then in 1978, Grunzig performed the first balloon angioplasty, and then several other techniques introducing the metallic stents, then the low-profile metallic stents on 14 wires, and even drug-eluting stents. It starts like this. This is typical atherosclerotic renal artery stenosis involving the proximal segment of the right renal artery. Performed stenting, and you expect the next day that you cure the patient, or at least you perform significant impaction on the patient hypertension and need for medication. Unfortunately, the numbers does not support this. After correcting, and I'm talking about atherosclerotic renal artery stenosis, after correcting the significant stenosis, less than 10% of the patient will achieve cure, which means their blood pressure will be normalized and they will need no medication for antihypertension. That's why in the recent few years, there are several studies started to question the value of what we do as far as revascularization of the renal artery. Just one notice before, for fibromuscular dysplasia, the case is different. You can achieve a cure in more than 80% of patients with hypertension and fibromuscular dysplasia, and the recurrence rate is relatively low. Okay. At least there are 4 or 5 prospective studies in the last few years to address this issue. The first one was published in New England Journal of Medicine in 2009, which called the Astral trial, Revascularization versus medical therapy for renal artery stenosis. The aim of the study was to evaluate the added value of renal artery stenting or renal function in patients with atherosclerotic renal artery stenosis. The primary outcome was to look at the renal function. And there are secondary factors they looked into, which include the blood pressure, time for major renal or cardiovascular events, which is the most important because you want for the patient's survival and events free. And also they looked on the mortality. The study was performed in the UK, multiple centers. In addition, there was some recruitment from Australia and New Zealand. More than 800 patients from 57 hospitals were randomized either to do medical treatment or medical treatment in addition to revascularization. It's very interesting, the inclusion criteria. If the referring physician thought that the patient is most likely going to benefit from renal artery revascularization, he was excluded from the study. And they only included the patients where the clinician was not certain whether to do revascularization or not. This is a key thing, and this was part of the criticism on this study. And they defined renal artery stenosis as 60%. They followed the patient for an average of 34 months. And as you see in the results, for the serum creatinine level, there is no significant difference between the patients who underwent revascularization and the medical group. For systolic blood pressure, also there was no significant difference between the two groups. Overall survival was also statistically not significant. So patients on medical treatment performed as good as patients on who underwent revascularization. As I mentioned, to summarize, the renal function there was minor deterioration in both the groups, but there is no significance between the two groups. Blood pressure was decreased in both the groups also, but was not statistically significant. Almost 2% of the patients per year went into renal failure, and this was similar between the two groups. As far as mortality and vascular events were the same. The conclusion of the study was that renal artery stenting has an added risk because there was almost 23 cases of major complications in these patients, but has no significant added benefits to medical therapy. The second study, which just published a couple of months ago in New England Journal of Medicine, what's called the Coral study, is stenting and medical therapy for atherosclerotic renal artery stenosis. The study was designed to try to avoid the criticism and flood that appeared in Astral trial. So the aim of the study was to test whether renal artery stenting added to a good medical treatment will improve the clinical outcome in patients with atherosclerotic renal artery stenosis. The medical treatment was standardized, and all of them, they were on ACE inhibitor. 947 patients with significant atherosclerotic renal artery stenosis they have either hypertension on 2 or more antihypertensive medication, or they have renal impairment, were prospectively assigned to either medical therapy or medical therapy plus renal stenting. And all the renal artery stenosis was confirmed by independent team in a core lab. The patient were followed for adverse cardiovascular and renal events like MI, stroke, congestive heart failure, renal insufficiency, and the mortality related to these events. Again, the conclusion was similar to Astral trial. After the follow-up period, there was the event-free survival was not significant between the two groups, whether you do renal stenting or not. Over a median follow-up of 43 months, the average follow-up, there was no additional benefits from renal artery revascularization over just medical therapy. The only difference they noticed between the two groups is a slight decrease in the blood pressure in the stented group by average of 2.3 millimeters with a significant p-value. However, the number of antihypertensive medications were the same between the two groups at the end of the follow-up. Well, right now, the last time the American Heart Association gave recommendation was 2005. They updated a little bit in 2009, but not separate for treatment of renal artery stenosis. We're waiting for the new guidelines and recommendations. And after this study, probably there will be a significant change. But I think most people agree about the current recommendation, about these general ideas about the recommendation. It's really not solid guidelines. One of them is hypertensive patient with FMD. Probably this is a patient you should give him the chance and treat him with balloon angioplasty. Rarely you need stenting in these patients because the recurrence rate is very low. Patient with a progressive decline in their kidney function during antihypertensive medications, including patients who could not tolerate ACE inhibitors. And have renal artery stenosis probably should undergo revascularization in addition to medical treatment. Failure to achieve the targeted blood pressure on proper antihypertensive medication. And also we shouldn't forget patients with certain cardiovascular manifestations, especially recurrent flash pulmonary edema or recurrent episodes of CHF, and they have normal coronary anatomy, no clear cardiac source of CHF or pulmonary edema. The last two subjects I will discuss is because of the a little bit disappointing, probably disappointing results or the effectiveness of antihypertensive medication and medical therapy. And in recent years, people try to improve the technique of revascularization, percutaneous revascularization. And I will touch very briefly about two subjects. One of them is the introduction of drug-eluting stents. The problem with, as we see in other vascular beds with percutaneous procedures, is the recurrence rate. Meta-analysis performed in 2000 showed that at 6 months, the recurrence rate for renal artery stenosis after stenting is almost 17%. 2001, Littleman performed angiogram on patients who already have renal stenting, almost 300 patients. He defined the in-stent stenosis by 50% stenosis. Risk of stenosis at 16 months was almost 21%. So it's still significant. And all the meta-analysis and this study showed that the risk of renal artery stenosis is more likely if the artery is small and the stent you're placing is small. That's why people suggested using drug-eluting stents in treating renal artery stenosis. One of the the only prospective study was the Great trial. This patient, it's a prospective multicenter trial to evaluate stent patency, drug-eluting stent patency. Patient were assigned either in bare metal stents, the patency was 92.3% versus in drug-eluting stents 98.1%. However, in stent percent diameter, late lumen loss, and repeat revascularization were lower in a drug-eluting stent group, but however did not reach the statistically significant degree. Therefore, probably the suggestion is to use drug-eluting stent in patients who have small renal arteries, because we know these patients are more likely to develop in-stent stenosis. Maybe patients who had already impaired kidney function and you're trying to avoid repeating angiogram and angioplasty, and maybe can be considered for in-stent stenosis. The other one is just briefly for what was noticed during the patients who are undergoing renal stenting, that there is transient decline in the renal function. And almost 26% of the patients who are going or undergoing renal artery stenting developed deterioration of the kidney function. 2% they ended on dialysis. I will be finishing soon. Post-procedure deterioration could be either to contrast-induced nephropathy, or the other entity is embolization while manipulating the wires and catheters through the atherosclerotic plaque. Non-randomized studies suggested there may be benefit with capturing these. So the only prospective randomized study was performed by Cooper, who assigned a group who did just stenting, the other group stenting plus protection device. The third group is stenting plus antiplatelets, and the last group is stenting plus antiplatelets plus protection device. The change in GFR was calculated at 1 month, and there was no significant difference between using the protection device. The only difference was if you use the antiplatelet and the protection device. And there is also, in addition, there is technical, in general, there is technical problem with using the protection device in renal artery if it's early bifurcation. I will conclude that renal artery stenosis is a fairly common pathology, especially in elderly populations secondary to atherosclerotic disease. Best therapeutic approach for significant renal artery stenosis is still being shaped by the recent clinical trials. With the recent introduction of new effective antihypertensive medications, probably good medical treatment of renovascular hypertension may be as effective as intervention, and still there are certain clinical indications to go and do renal artery revascularization. Thank you very much.